Hi, everybody. It's Karen Anderson here with Aortic Hope for a very special live event tonight. Before we even get started, you know the drill. You know what you got to do. I'm going to ask you to click like because it really makes me feel good about what I'm doing. Click like, click subscribe, click that bell so you're notified every time we go live. I know a lot of you with your pump head don't remember what we have happening. That's fine. Let the computer work for you. So click like, click subscribe, click the bell, and then you're going to find out every time we have great guests like we do tonight for tonight's live Q&A. We have Dr. Sbrocchi with Baylor Scott and White. And I'm glad I didn't butcher your last name. I've been practicing all day. And the crazy thing is we literally just met in like the last 12 minutes. So it's a very fast, just try to get to know each other real quick situation. So I'm going to let Dr. Sbrocchi tell you all about himself before we jump into tonight's live Q&A, which is going to be all about the aorta and aortic dissection. So get ready with your questions. You can put them in chat. Know that they're going to live out there forever. So if you'd rather be anonymous, use the link that's provided below, and we will ask those questions for you. Hello, Dr. Sbrocchi.
Hey
Welcome.
there. Thank you. Thank you for having me.
Good to
Yeah,
have you.
so I'm AJ Sbrocchi. I'm aortic and cardiac surgeon here at Baylor, Dallas. I've been here about 3 years now. Finished up my training in Charleston, South Carolina, and came straight here, and have been kind of busy ever since with Dr. Roberts and the aortic clinic, and just try to help the people of Dallas and Texas with their aortic disease and whatever else they have going on.
Were you at MUSC?
I was, yes.
Yeah,
Yep.
I've got friends that work around that area. So that's,
Oh,
yeah,
very nice.
that's a great area out there, although it seems to flood quite a lot when the big storms come through.
It
Yeah, it
does,
does.
but it's
Right.
pretty.
That's right.
Yeah.
Exactly. So listen, I want to get into just explain to people. I love different physicians' descriptions of and how they want to talk about the aorta and aneurysms. I love all of the metaphors people use. I can't wait to hear yours. So tell everybody a little bit about the aorta, and then we'll get into some of the disease elements.
Yeah, so the aorta is obviously the biggest vessel in our body. It kind of branches out and gives off everything. Dr. Roberts always refers to it kind of as a candy cane because it does quite literally look like a candy cane. But it's kind of one of those gentle giants where it does all the work from the heart, but sometimes you can obviously have very, very bad problems with it.
Yeah. So we've been talking a lot here. Like my community is very well schooled about the different zones of the aorta. So as in terms of what would be most critical or the highest volume, what would those be for people, and why should they be aware of some of this terminology?
Uh, from my standpoint, being a heart surgeon, in my opinion, zone 0 is probably the most important. So that's basically everything that comes from the aortic root, so the valve itself, all the way up to the first branch, the innominate artery. It gives off your right arm as well as part of your head vessels, because that's the one that can cause the most catastrophic events if there's a tear in it.
Okay.
Yeah, but
So if
there's
there's a
obviously a bunch.
dissection there, that's what's called type A, correct?
Correct. Yes.
Okay.
Yeah.
Okay.
Yep. And so yeah, it can make the aortic valve, which is just below it, extremely leaky. But then also there's obviously downstream effects of it in basically every other zone if there's a tear that starts there.
Right. And so explain, if you would, an aneurysm to for all of those that are listening that have an aneurysm.
Yeah, so an aneurysm itself is, by definition, anything that's over 4.5 centimeters, at least as far as in the ascending and the proximal descending aorta.
Mm-hmm.
It's technically anything that's over 150% of normal, further down in the body, but it's basically just a ballooning out of all 3 layers of the aorta itself. That's abnormal, at least compared to normal itself.
Do you think that there's maybe discrepancy between the radiologists that are doing the CT scans or MRI scans? Because I think a lot of times the results come back, somebody has 3.9 or 4.2, and they're told that instead of saying they have an enlargement or dilation, they're told they have an aneurysm. And so people come to the community and like, oh my God, it's 4.1 and I'm 6'4", 215 pounds. And and I'm like trying to get them to breathe because I can't tell them because I'm not a physician. I may have my opinion, but it's like I have to gently kind of say, wait till you talk to your doctor. And I'm not trying to denounce the education or the opinion of a radiologist, but do you find that sometimes there's a let's just jump in and call things because there's just so much different terminology between enlargement, dilation, aneurysm. Can you talk a little bit about that?
Yeah, that's an excellent point, and honestly, that's a lot of what our outpatient clinic is about. Is that
Okay.
From our standpoint, anything under 4.5 centimeters is considered dilated, but not
Mm-hmm.
an aneurysm.
Okay.
But to your point, people say our technical term is ectasia,
Mm-hmm.
meaning a little bit windy.
Mm-hmm.
But yes, you're right. We see patients all the time that they're told that, oh, it's 4.1 centimeters. You have an aortic aneurysm. Go see your heart surgeon, and don't move. and
Don't
it causes
breathe.
a lot of stress. Exactly.
Yeah.
Yeah. So it causes a lot of stress and anxiety, and a lot of that is us kind of just educating.
Right.
But yeah, that happens all the time as far as the radiologist or anyone who sees it.
Yeah.
Yeah.
So I could have 1 million questions for you, but I know you have slides, so I'm going to let you do that first, and then because you're probably going to cover much of what I want to talk to you about. So if you want to jump in and do that, I'm just going to mute, and I'll only pop in if I have a really important question. I'm going to take notes.
All right. Are you able to see my screen, or let me share again?
Yeah. Yep, that's
Good.
great.
Perfect. Okay. So I'll hopefully touch base on aneurysms, dissection, rupture, treatment, diagnosis. We could be here for a couple of days doing that, as you know, but I'll try my best to make it short. So to understand all this, you have to know just basic anatomy, which is easier said than done. But as I said, zone 0 is the portion that includes the aortic valve itself, the root that we call it, as well as your coronary arteries, and then it goes all the way up and includes the innominate artery, which, as I said, gives off the subclavian or the arm, as well as the first branch to your head vessels. And then they're broken down into zone 1, 2, 3, all the way down. So all the way down into your mesenteric or your abdominal arteries. It gives off your kidneys, and then all the way down to your legs. So, they've over the years they've come to segment out the aorta into these 12 zones, and that's what we treat based on. So as I was saying before, an aneurysm itself is just that dilation over 4.5 centimeters, but it does have to involve all three walls. There's some other technical terms like pseudoaneurysm and things like that are a little bit different. But on the left here, you can see a diagram, at least, of the ascending aorta with a dilation. On the right is actually an intraoperative photo of the exact same thing. Off to the right here, you can see the pulmonary artery and the heart itself. Just below, you can see how big it is. It almost takes up the entire mediastinal cavity there.
What size is that, if you don't mind me asking? I'm just curious. Do you have any idea?
I couldn't tell you off the top of my head. Probably 5 or 6 centimeters would be my guess.
Yeah, that looks pretty big. Okay.
Yeah. Obviously, normal aortic sizes, I put in quotations there because, like you said, it varies for everyone. I'm about 5'5", so a 5 centimeter aneurysm in me would look huge, versus if somebody's 6'4", 6'5", and 200 some odd pounds, their aorta could be 5 centimeters, and that could be closer to norm for them.
Right.
But so it is important for us to take into account the taller, the shorter patients, weight, all that, as well as gender. So it causes the aorta to dilate. It's normal to grow a little bit as you age, about 1 millimeter a year. Sometimes I tell people as you get closer to 80 and you start to shrink a little bit, of course it's a tube it's got to go somewhere, and if you're shrinking, your aorta is probably going to go a little bit wider. Sex, so females, for some reason, tend to dilate out a little bit sooner than males do. And then the three that are underlined here, high blood pressure, smoking, and atherosclerosis. So things that are involved with diets. Those are the big three, and those are the things that you can change. That we all have a say over, whether it be taking medication, stopping smoking, having a better diet. But those are the things that we can alter to prevent our aortas from dilating. And then
once they've grown, just to make sure everybody hears this, they don't shrink because you've eliminated salt and now you're working out, correct?
Correct. Yep.
Yeah. Okay.
And that's an important question that we get all the time as well, is, what medications or what can I do to make it not grow, or to shrink it? And unfortunately, there's no good answer for that.
Yeah.
And of course, the one that we can't change is our family history or genetics, which we're learning a lot more about as the years go on. So aneurysms, unfortunately, can progress all the way to dissection. So on the right is a dissected aorta. And that is when the walls, basically blood enters the walls of the aorta, and think of it like an onion, starts to split those layers apart. So on the left there, you can see the separation of the media, or the middle portion of the aorta, from the adventitia there, which is on the outside. And it leaves that much thinner wall over here. And then on the right here, it's the same thing, but this is a blood clot that has basically formed over time. And so that dissection itself causes two lumens, a true lumen, which is where the blood is supposed to go, and then the false lumen, which is where blood is not supposed to go. And that's where the vast majority of the complications come from, is when that false lumen is getting the blood and it's not supposed to.
So on that picture on the right, that big center section that looks like a big chunk of bone marrow, is that true or false lumen?
That is false lumen.
So right. So it just shrinks down the amount of blood flow you actually have going to all of your organs to that little clear empty space on the bottom.
Exactly. Yes.
Okay. Yeah.
Yeah. So that's where all the downstream issues arise, unfortunately.
Right. Yeah.
So in the most granular way we can put it, there's basically two types, or two areas of dissection. We call them a type A and a type B. So type A is anything that starts in the ascending aorta, so in that zone 0 to zone 1. And then type B is anything that begins after the subclavian artery, or anything after that third head vessel artery going down.
Okay.
Now we haven't particularly defined anything that happens between those two zones. We tend to think of them as A minus or B plus, something like that. But that's like you alluded to, there's a lot of new technology to kind of help us bridge that gap over time. And aortic dissection, as we know, is not a great thing to have. If you look at all over the last probably about 40 years, the mortality of it has remained mostly unchanged. Those who suffer in acute type A, the mortality is, even operated on, is upwards of 20 to 30%, depending on which studies you look at, and acute type B dissections are about 12 to 15%.
So in regards to this, I know I apologize. I know I said I was going to be quiet, but I'm so fascinated. I love doing these because I have a chance to learn and I start taking a million notes. So when people that are new in the community come in and I had an 80% chance of dying, I had a 20% chance of living, are they maybe just going by things that they're reading on Google? Because to me, it seems like you almost would have an 80% chance of living if you can get yourself to the hospital. What are these overall general stats compared to this? What are people sharing when they say that?
Yeah, so that's a good point. So historically, it's been about a 20 to 25% chance of just sudden death right when a dissection occurs, and then it's about 1 to 2% risk of dying per hour before you get to the operating room.
Okay.
Because these are true surgical emergencies, at least for type A dissections. Yeah, so to think of it as I have an 80% chance of living or a 20% chance of dying, I think is maybe a bit grim, because if you look at all comers, and it depends on where you go, because outcomes are much better at high volume institutions. And it's just because it's a whole team approach, and everything from getting in the door to the operating room to the post-operative management and long-term management is much better. So I think that's why those outcomes are a little bit better. But this is all comers.
Right.
Yeah, and to put it in perspective, the majority of operative cases that we do, the operative mortality is about 1% to 2%. So it's a much higher mortality risk. And the most feared of them all, I don't have an operative photo because it's pretty rare, but the rupture itself, which is when that thin walled layer kind of finally goes out and the blood comes out of there. It's just kind of, for the most part, it's a 90% plus mortality, just because we can't do much at that point.
Yeah.
So as far as the diagnosis goes, like you said earlier with the think aorta, most patients come in with a kind of a tearing chest or back pain that can go all the way down the back. It can present a lot of different ways, just as far as a stroke, a weakness, a tingling, not being able to move your legs, shortness of breath. It can be highly variable. But the gold standard is a CT scan, which I show on the right here. So this is at least for aneurysm, as well as dissection. But the gold standard, it shows us the aorta itself in the best detail we can get. On the left is an echocardiogram, or an ultrasound of the heart, which is also very important because it can show us the size of the aorta, although not as reliably, but it can show us the aortic valve itself to see if that's involved at all, or if there's any issues with that, or also how the heart function is doing. Yeah. And then we usually, depending on the size, family history, when we discovered it, it's usually annual surveillance, but sometimes it's a little bit shorter depending on the size, growth, things like that. And treatment options. We'll go a lot more into this a little bit later, but obviously elective repair is always better than urgent or emergent.
Yeah.
So basically we try to electively repair anything that is symptomatic. So if you're having chest pain and for no other reason, we've ruled out your coronaries or anything else going on. So any symptomatic aneurysm, anything over 5.5 centimeters, or anything that's growing at a specific rate. So a couple millimeters a year, or a couple millimeters every 2 years. The descending portion is usually about 5.5 centimeters, unless you get a little bit lower into the abdomen as well. And again, these are preventative, so the operative mortality rate of this is about 1% to 5%, depending on how much you're doing. But as I'm sure you and many people have kind of figured out, dissections don't always tend to just happen at 5.5 centimeters. So, they can happen all the way to 3 centimeters. Just because the average is somewhere around 5.3 doesn't necessarily mean that everyone falls into that category, unfortunately. So Yale actually, this is one of my favorite things to show patients, because it's pretty hard to tell somebody that you need elective heart surgery. You feel fine, but you've got this aneurysm inside your chest and we need to fix it. But they have a really great aortic center and data collection and publications, but they basically show that these two hinge points is when your risk of something bad happening, whether that be a rupture, dissection, anything. And they found basically two points, one at 5.25 and one at 5.75. That's where part of the 5.5 centimeter recommendation comes from.
Now, if somebody came in but they haven't had any genetic testing, but They knew that their grandfather died suddenly. Everybody just said it was a heart attack, but nobody gave no, there was no autopsy. And then their parent, their child, your parent, has an abdominal aneurysm, which for a man is not necessarily unusual, but it's still something. Would you maybe consider a lower threshold at that point then, because there could potentially be a family history link there?
Yeah, yeah, absolutely. So
Yeah.
all of our guidelines, for the most part, are a first degree relative. So
Okay.
at least brother, sister, mother, father.
Hmm.
Grandparents are a little bit tougher, and like you said, it's usually a mixed bag of history.
Hmm.
That oh well, they passed away, we don't know why.
Right.
Um, anyone who has a relative who's had a dissection or an aneurysm under the age of 60, we tend to refer to genetic testing, but also be much more aggressive on. But like you said, I think an aneurysm anywhere in the body that's known warrants kind of a little bit earlier, kind of more aggressive involvement in surgical recommendation.
Okay. Thank you.
Yeah, and kind of like you said, there's obviously things that lower them. So, and with that Yale data and a couple of others, and what we've learned over the years, they actually changed our guidelines that allow us to lower it to 5 centimeters in experienced centers. So basically anywhere that does at least 30 aortic procedures per year, and then a lot of other risk factors. So family history or personal history of just any aneurysm, the length of your aorta, the size of the patient themselves, their age, or even if it's growing a little bit more aggressively as well. Again, this is out of Yale because they do great work. This again shows that the aorta itself, if it's long, at least in the ascending aorta, and over a certain length, the risk of bad things happening goes up quite substantially.
Hmm.
And this is the area that I'm kind of talking about. So we can measure the length all the way from the aortic root up to the innominate artery there, and if that's over 11 millimeters, then you're at a much higher risk of dissection or rupture.
Okay.
And special populations. There's a whole slew of people. I didn't put them on here, but these are kind of the most common ones. So those with bicuspid valves are probably the ones that we see most in the elective realm. Here's a bicuspid valve that just has basically 2 leaflets instead of the 3. So if you're operating on that valve and the aorta itself is 4.5 centimeters, we tend to replace the aorta itself. Those with a family history, or anyone who's had a sudden family history with a sudden cardiac death under the age of 50 tend to be more aggressive. And then patients with connective tissue disorders. And then there's a whole slew of genes that will also lower the threshold quite substantially in most patients. I don't want to get into all those, but there's
a lot of letters and numbers and things. Yes.
Yep. Yeah. So that's probably about 60% of what we actually test for. Yeah. But we're learning a lot more, and we've gotten much more aggressive about genetic testing over the last couple of years. So we could spend a couple hours talking about the considerations of what to do and when. Mm-hmm. So the things that kind of go through our mind is we think of things from bottom to top. So the root itself. So if the aortic valve is involved or not, whether or not to replace that, there comes with a smaller risk of having coronary complications, because if we replace the root itself, we have to replace the coronary artery origins. There's a little bit of risk in that. There's some fancier things that we can do as far as sparing the aortic valve if the anatomy is appropriate, and then how much to replace as well. People with bicuspid valves, once you take out that bicuspid valve, it tends to not have the aorta itself grow anymore. But those who have large aortas and a normal valve tend to be a little bit more aggressive on as well.
Okay. What is resuspension? What does that actually mean? A lot of people I know we always say, do you still have your valve? Do you have your valve? So what does it
Mhm.
mean when a physician says they've resuspended your valve?
Yeah, that's it's kind of tough to
Mhm.
answer without kind of a drawing. It's basically we take stitches above the commissures. So the commissures are where the valve leaflets meet up on the edges,
Mm, okay.
and basically take usually pledgeted stitches to help pull the leaflets themselves back to where they're supposed to be
So you're
and
kind of like, it's almost
reattach
like
it.
a facelift for the valve. It seems like you're just
Yeah,
tweaking, you're just tightening it up a little bit.
yeah, it's a good way to
Okay.
put it. Yep,
Okay.
absolutely. Yeah, and that helps to prevent any further dilation or any
Hmm.
damage to the valve later on.
Right.
But it doesn't add very much. But yeah, it's a good technique that we do basically in every dissection and in a lot of aneurysms as
Hmm.
well, just to stabilize where that valve is supposed to be.
Okay.
Yeah, I've never actually had somebody ask me that. It's a tough one.
I would think you could only do that probably if someone had, if it was just like slightly aortic regurgitation. Because I would think if there's stenosis, it would probably be challenging to tighten that up. You would have to
Yep.
repair it, replace it.
Yep. Yeah,
Okay.
absolutely. Yeah.
I've been paying attention. I've been learning.
Yeah. No, I appreciate that. Yeah. Um, yeah, so just as far as general treatment goes, this is
Hmm.
again kind of in the elective realm, but an ascending aneurysm itself, this is just an ascending graft. Um, Basically, all of the replacement grafts we use, at least open surgically, look about the same. They're tube grafts that are Dacron, which people tend to ask a lot of. And then on the right here is what we call the hemiarch. So we are actually replacing part of the aorta just under the head vessels. And this is our most common operation that we do during type A dissections as well. Like I said, with the roots, you had a little bit of complexity, but here are the coronary artery, the origins of them. And that's why I said that it adds more complexity and a little bit more risk just because they're much finer anastomoses. This is what we call the Bentall procedure, where the valve is replaced with it.
Mm.
And then, like I said, there's a much fancier where you can actually spare the valve and replace the root, but keep your native aortic valve, which kind of is reserved for certain anatomy that's much more favorable to us. Aortic dissection, the treatment itself, so at least in the ascending, is, like I said, a true surgical emergency. And there's a few goals for that. So our goal is to remove the entry tear, so that the spot where the blood is coming into the aorta and causing that separation of the layers, to replace the ascending aorta itself, to obliterate that false lumen, which is easier said than done, unfortunately, and then to correct the aortic regurgitation, which is usually with the aortic valve resuspension. And on the right here, that's what it looks like afterwards, even though it's a large operation and it looks like just a small little piece of graft. It's still a very large operation. And then, like I said, there's a whole slew of other things that you could do either at the time of dissection or an aneurysm replacement. I kind of put in here a variation of everything you can think of. There's the hemiarch. There's replacing just a majority of the arch or the whole arch, parts into the descending. There's other options to kind of put little branch grafts off everywhere, and there's a lot of different options depending on what the person's disease process is like. And
So
each of those.
if you have the ascending, sorry, I don't mean to interrupt. If you have the ascending, whether it goes, okay, let's say it goes into the arch, and you're replacing it, like you were saying, let's say you do a hemiarch repair. What's the what's the probability someone's going to develop an aneurysm on the proximal descending? So right across from your ascending, just so everybody knows what that means. What's the chances that someone does develop, like you have here in the picture, another aneurysm?
So if it's just an aneurysm, very, very low. I couldn't tell you
Okay.
the exact percentage. Probably somewhere in the 2 to 5% range.
Mm-hmm.
Obviously, having one puts you kind of at a higher risk of having another, but overall, it's relatively low as long as it's isolated just to the ascending portion.
All right. So if you've dissected, if you've had an A that then turned into a B, so you're all the way from start to finish. Um, and I know people are medically managed usually in that situation. It's kind of like a let's just get in, do what we need to do and get out, right? Because it's
Mhm.
the ascending is the most critical. Why aren't people putting in a graft right when they have an opportunity just to reinforce through the arch and just get it down versus maybe in time someone's going to need to have an additional repair?
Yeah,
Like
that's a
why
good
medically
question.
manage? Yeah.
Yeah, that's a good question. So some people are very aggressive about that. We tend to be a little bit more aggressive in very young people about replacing the whole thing.
Mm-hmm.
But each couple of centimeters that you add operating to or replacing comes more risk. So
Okay.
Penn actually had a really good paper recently that looked at all their patients over the last about 20 years and found that the in-hospital mortality, as well as stroke, renal failure, and one other thing, stroke, renal failure, and length of stay were all much shorter in just doing the hemiarch replacement, knowing that in the longer term that there's a higher likelihood of needing more interventions. So basically, if you replace the entire arch, you're at a higher risk of paralysis, stroke, death, staying in the hospital longer, but less likely to actually need reintervention later.
Okay.
And now what we're kind of doing a lot more of is doing that hemiarch and replacing that first branch of the aorta, the innominate artery.
Mm-hmm.
And that is just because it allows us or the vascular surgeons to have some what we call hybrid approaches with stent grafts to be able to cover some of that dissection later on.
Okay.
But yeah, to answer your question of why manage it medically, not all of these things progress into something worse, which is good, and there are still options endovascularly, but it's always kind of a risk versus reward. And I'd say the majority of patients, once they get their blood pressure under control and everything, they tend to not progress.
Okay.
And then we could talk about just isolated type B dissection. So nothing in the ascending or arch, but beginning just beyond that left subclavian. And again, you can kind of see the true and the false lumens there. And it can go all the way down. It can stop just at one of the vessels themselves. They tend to be a little bit easier to manage. Usually if there's just an isolated type B dissection and somebody comes into the hospital, we do medically manage them. We get their heart rate and blood pressure under control. And if there's no ongoing chest or back pain, if there's no end organ dysfunction, like the kidneys are still working, the belly's still working, and you're not having ischemia to your legs, then usually we can just medically manage it like that, and the outcomes are pretty good. Now, if you're having other issues like the ongoing pain, blood pressure can't be controlled, kidneys aren't working, then that kind of puts us into having to do something with that. And fortunately for most people nowadays, the open repair on the left that you see is not needed anymore. Most of them they can just do endovascularly. I say most, obviously not all. I don't do any of these. The vascular surgeons do a vast majority of them, thankfully. But they've gotten very, very slick at being able to, put in a stent graft and even extra little limbs to the kidneys or the abdominal viscera as well, which is very nice. And the recovery is much less than having a sternotomy and all that. And like you said, the residual dissections after a type A repair is it's a really hot topic nowadays. Every meeting that we go to is, this is kind of at the forefront of everything. And like you said, this is, that's kind of the thing that everyone thinks of, and why just medically manage it. And the big answer to that question is because there tend to be a lot of these tiny little fenestrations, so other little openings further down. So even if you plug one, you might still have that opening somewhere else.
Mm-hmm.
So we usually just medically manage them with blood pressure control and lifestyle changes. And like I said, why not fix it all at the same time? Higher risk of stroke, death, renal failure, paralysis. And the recovery and long-term outcomes. So recovery is variable. Some people just have an isolated tear to the ascending aorta, and their recovery can be much easier. If they had a tear that goes all the way down, and they had some kidney issues and have dialysis, they could be spending a lot more time in the hospital. So unfortunately, it depends on kind of where these tears go. That dictates how long your recovery will be. We like to tell people that it'll be 2 months and then you can go back to living your life and not having sternal precautions. But as you know, it's not that simple. It's not your elective heart surgery.
Yeah. Well, and I think that part of what's missing, in my opinion, from this whole list is the emotional and mental effects of having something that a near fatal experience, having a traumatic event. And I was talking with another doctor once, and he made a good point that sometimes it starts in the ER when that news is delivered to you, whether you're fully aware of what a dissection is or not. When you're told you got 5 minutes to figure out where we're going to life flight you because, you could die. It's from that moment on that the patient's mind and psyche completely changes. We're in fight or flight mode. We're going into shock. We're out of here, but physically we're still here. And I think that recovery really can take a long time until you notice what's really happening. A lot of people, they just ignore it. And because they're so focused on physical, we're so focused on the sternum knitting like any other broken bone, and breathing and all these new medications. And do we complain to the doctor that we're exhausted, fatigued, and fuzzy in our head from the meds? And so there's so many different things that this is a true list, but is it really? There's so many variables. And I don't know that a lot of patients are really given the tools to understand what this new body that you have to settle into is going to feel like, and that it could really take a lot of time before you feel that 2.0 version of yourself.
Yeah, no, I agree entirely. I think that's one of the biggest keys, because it's you go from living a regular life to having not only that mental aspect of am I going to drop dead at some point because of this, or is it going to get worse? And then you have yearly CT scans. You have now you just have 5 doctors that you have to see once or twice a year. It's not a simple task for people to undertake.
No. And every time you walk into a new doctor and they're going through your medical history and then they gasp when they look at you and they're like, I can't believe you're sitting here. It just brings it. No, nobody thinks that it's like, oh, yeah, lucky me. You just don't. It just brings it right back, which is which becomes really hard. It takes many years. I mean, I'm at this now 10 years and it's still a little tough when somebody looks at me like, this is insane that you're sitting here in front of me. I just went for a blood test today and I am much better than I was, but I have to tell everybody, hey, listen, I can take open heart surgery, crack my chest, but don't stick a needle in my vein. Like, I have to know you know what you're doing. I'm just going to talk a lot, ignore me. It's what gets me through it. And she's kind of laughing, and I didn't even feel, she was great needle stick. She was awesome. But still, when you tell them, they're just like, you had what? And you're sitting here. I'm like, oh, please don't put icing on the Sunday right now of my nerves, But I like that you have this information here, and some people think that not lifting 10 pounds is for the rest of their life, which we try to explain that depending on your situation, obviously, it's more than likely isn't for the rest of your life. I mean, you've got a sister, or you have a wife, or you have a mother. Any females go away for 24 hours. How much did their suitcases weigh? It just is.
Right.
It's going to weigh like 38 pounds. Easy. And I sometimes have to pull it out of the trunk. I'm not lifting it in the overhead bin. I'm not that dumb. But you got to do what you got to do. You might have a toddler or a young child at home, and you just
Mhm.
have to learn how to lift, how to breathe through that lift. And it takes some
Yeah,
time also.
yeah, yeah, and that's very
Yeah.
important. And I mean, there are people who had a dissection 2 years ago, and they
Mhm.
are still saying, "Oh, I'm not supposed to lifting over 10 pounds,"
Yeah.
and you just have to tell them you got to live your life, but don't do Olympic weightlifting, obviously.
Right.
But yes, it's about learning how to lift, and exercising is important so that you can
Right.
still be around for as many years as possible,
Yeah. Yeah.
because you still need to be
Exactly.
healthy everywhere else.
And then we've had conversations too about CT scans, and I want to know your opinion on this. So I know they say that that's the golden standard, and I'm wondering, is that the golden standard because you're in an ER and it's the fastest thing? You can bump the next person. It takes 5 minutes, get them in, hit them with the dye, and you have your results. But for people who are allergic to the dye, that's still going to be about an hour, pre medication protocol, but it's
Mhm.
still the gold standard because you can still bump somebody to stick me in before them. Whereas the MRI, do you feel still has as good of a picture and an outcome? Because that's what I have. First of all, I don't mind sitting in there for 40 minutes. I sleep, I dream, I think it's fine. It's relaxing to me. But I
Mhm.
also have like an anaphylactic reaction to the dye. So is it purely because it's the best picture that you can possibly get? Or is it really because it is the fastest, it's the most convenient, and it's going to give you a good picture when you're in an emergent situation?
Yeah, yeah, absolutely. It's a little bit of both.
Okay.
It's the MRI technically is actually it's a better scan,
Hmm.
because it can be gated much
Right.
better, but it's much more costly and much more time. It has a much longer time commitment than a CT
Hmm.
scan does.
Yeah.
So in our aortic clinic, I think we have 20 or 30 people a day, who are getting scans, and
Hmm.
each one takes an hour. You're not going to be able to do MRIs on everybody.
Right.
Um,
Right.
but yes, they're fast, they're heavily reliable, and they're good comparisons,
Hmm.
because you can't always compare MRIs to CTs or even CTs to echoes, because they're just not the same imaging, and
Yeah.
especially with echoes, it's very tech dependent. But yes, MRIs are great.
Hmm.
The other part too is that not everyone can read them.
Hmm.
I know that myself and probably most other heart surgeons across the country can't read a cardiac MRI. I mean,
Hmm.
we could look at it and say that's not normal, but everyone can read a CT scan much
Right.
easier.
Okay.
Mhm. Um, oh, there you go. And genetic testing, like I said, is becoming one of the really hot topics. Like I said, we've gotten very aggressive about it, but like I said, everyone with a first degree relative who's had a dissection, it's a little bit harder to do with aneurysms, but anyone who's at least had a dissection itself can at least get insurance to pay for it. Anyone with a family history of dissection at all can get genetic testing for it.
Hmm.
And then, but basically because up to 20% that we know of are inherited.
Hmm.
Um, yeah, so basically we've been much more aggressive about this, but even for future research, just to really know what is out there, and what genes are actually going to be involved, and important to look at.
Hmm.
My key takeaways here, if I can, do anything, is that elective is always better than emergent. Your
Hmm.
outcomes are better. It's obviously one of those things where it's really hard to tell somebody, you have this balloon in your chest, let's operate on it and take the risk. But like you said, it becomes a lifelong disease.
Hmm.
Actually, I had a patient a couple of weeks ago who was supposed to have ascending aneurysm replacement done the week before, got it delayed for some reason, and came in with a dissection that went all the way down. And it
Yeah.
literally went from a 1% risk to mortality to, a lifelong management.
Right.
Um, Blood pressure management is key as secondary prevention. It's kind of hard for people to do. Not everyone always has the best home care, but just something silly like checking your blood pressure twice a day quite literally can save your life if you have high blood pressure. Keeping the lifelong surveillance of CT scans, as not fun as that is for a lot of patients, is crucial. And then having the institutional approach and a multidisciplinary approach is great. I mean, we have nephrologists who manage blood pressure. We've got vascular surgeons, our cardiac surgeons. We've got geneticists. We have, it's just you guys, the nurses, everyone. I mean, the having all that is what's important in keeping people alive and doing well. And then, like I said, control what you can. The things, you can't control your family history. You can't control your sex. You can't control your genetics, but you can control your blood pressure and life choices.
Exactly.
Yeah.
Great presentation. Good job. I love it all.
Thank you.
It's wonderful. All right, I'm going to check in with Josh real quick and see who is out there that we need to say hello to.
Let's say hi to the chat.
Okay.
We've got Molly and Dan so far.
Okay.
And we have a couple questions and an anonymous question.
Sure.
Everybody else is being shy.
That happens.
So the first question here is, what got you interested in becoming a thoracic surgeon? And if you could, doctor, could you kill the share, please?
Oh, yeah. Sorry. Is that better? Is it
much better? Thank you.
Okay. Yeah. So what got me into being a thoracic surgeon? So my uncle is actually, he's a retired vascular surgeon, but so I saw when I was in high school, we did this high school project where you go look at lawyers, doctors, whatever. And I saw a carotid surgery with him, passed out twice during that. And then, the next day, actually, I went and saw a heart surgery. So,
yeah, you're
click
tapping
your camera. There you go.
So the next day, I saw a heart surgery. He brought me into that room, and I was hooked immediately. And then, as I was going up through college and medical school, everyone just kind of said, well, heart surgery is dying off, stents are going to take over. And, so I tried to look at everything else. I tried to look at vascular surgery, general surgery, looked at cardiology, pulmonology, and just couldn't do anything else. It's like the pathology, the physiology too much.
Very good question.
I like that answer. I like that a lot. You got cornered into helping this community. I'll take it.
Yep.
I'll take it.
Yeah. It's not the best lifestyle, but it's a good career for sure.
Well, as Dr. Udeman out of Maimonides says, you have a rare opportunity to become a family doctor, because you're going to be treating patients for life and then possibly their family as well. And that's not something you see in the surgical line.
That's true.
Yeah. How common is aortitis and aneurysm in dissection patients? How do you diagnose it?
Aortitis is a tough one. We don't see it all that frequently. You can see it on CT scans pretty well if you have a very good radiologist who can read it. It's usually like a thickened wall that just doesn't quite make sense, but we see it in patients with like lupus, other autoimmune diseases. So the fortunate part is that oftentimes aortitis is treatable just with treating the underlying condition. Usually with steroids and re-imaging them. There's obviously other types of aortitis or aortitises that are kind of more genetic, like a Kawasaki's disease or something like that, or even aortitis with infection like syphilis. But overall, they're pretty rare. I'd say maybe see one a year. As far as aortitis converting into a dissection or rupture, probably even more rare, but we kind of see that after the fact, obviously because they show up as a dissection, and then you look at it and you say, this is extremely inflamed, something else is going on. But again, that's probably once or twice a year.
Okay.
But yeah, in the elective realm, say, having aortitis and needing an operation is pretty rare.
Okay. Dan here joined the chat, and he says, "Don't put the toddler in the overhead bin. Flight attendants go crazy when you do that."
Did I say toddler?
No, you didn't.
You just don't put the toddler in.
And then he says, "Annual CT scans. I am unaware of annual CT scans." Now, I have in this community heard of people being told that they have an aneurysm to come see them again in a couple of years, right, for a follow-up. And every time I hear that, I'm always like, why would somebody say that?
Yeah, so it all depends. You know, we have a lot of patients that we've seen for quite a while. At least the guidelines are annual CT scans for 5 years, at least for aneurysmal disease. Now, in the abdomen, a lot of times they will go straight to just ultrasound of the aorta. But as far as ascendings, we do CT scans annually for 5 years. After that 5 years, if they've been stable, then we tend to space it out to every 2 or 3 years. Sometimes you can go a little longer depending on what how big it is, things like that. But yeah, I mean, if somebody's been seeing me for 5 years and their aneurysm is 4.4 and it's been 4.4 the whole time, then say, okay, I'll see you in 2 years, and then after that maybe 5. You know, but you know, so some people will do just echoes, which is just not as reliable. You can get different measurements year to year, and so that's just, you know, we usually don't get that. People who have had a dissection should get annual. That I think should never change, because you never know, at some point that residual dissection could degenerate, and if you miss it for a year, it can be something catastrophic.
Right.
I agree, doctor. And Josie Kyer says, "This was excellent, so helpful."
Very good.
Thank you.
Very
Thank
good.
you.
Right on.
Okay, I have a couple here. If a type A dissection patient is stable and has been for 4 years via echo and CT scans, would you recommend maybe transitioning to a cardiac MRI once a year? People
Yeah.
get scared they're going to glow. They're going to be radiated so badly over their lifetime. So
Yeah, I think it's reasonable. You know, part of that question is insurance reimbursement. Is it going to pay for you? If people ask and they want it, then absolutely, like that's fine. You know, depending on where you look, a CT scan, chest, abdomen, pelvis, and cancer risk is always people's kind of concern. But I think it's like 1 per 100,000 patients will wind up with a cancer from chronic CT scans.
okay.
Now, if you're getting scanned every 3 or 6 months, it might be a different story. There was a paper that came out more recently that I think the rates are actually getting higher than that because people are getting scanned so much.
Yeah.
But yeah, I think it's definitely a good idea, and especially in those patients who are much younger. You know, even realistically under 50 or even under 55. I mean, if you add that up, you're going to get a lot of scans over your lifetime. So it's probably wise to switch to MRI.
Okay. How has new technology and advancements in surgery techniques or surgical techniques changed how aortic dissections are being treated?
Yeah, it's kind of been going back and forth. So there's, like I said, the kind of gold standard or minimum is that ascending and hemiarch. You know, I think as we see what the downstream effects are of not treating something further, then we've started to get a little more aggressive into the arch. But we tend to reserve that for somewhat younger patients. And part of that's because the vascular surgeons and endovascular options have gotten so good. You know, I mean, as long as they have some landing zone for their grafts, they can stent into the subclavian. Sometimes they can stent into the carotid.
Yeah.
They've gotten very, very good at that.
Okay.
Yeah, I mean, there's new dissection stents that we can put in at the time of a type A repair that helps to stabilize the arch. So I mean, things are getting very, very good,
Mm-hmm.
but obviously not perfect yet.
Okay.
You know, but we're every meeting everywhere is still struggling with what do you do with that residual dissection downstream, and
Mm-hmm.
you know the big problem is if you try to repair or fix it all later on, there's a very real risk of paraplegia and something bad
Mm.
that can happen. So yeah, the consensus is still out a little bit.
Okay. Do you contribute anonymous data about your patient's aortic dissections for statistical or research purposes? This person's curious how often individual cases contribute to broader medical understanding. If so, like, where do physicians send that information?
Yeah, so what we it's voluntary to answer that question. So there's
Mm-hmm.
the IRAD database, which is what the data that I showed earlier. So that
Mm-hmm.
is where everybody sends their data from dissections and aneurysms as well. But
Mm-hmm.
it's entirely voluntary. So there's a lot of programs out there who aren't doing it. So all that data is a little bit skewed because
Right.
people aren't going to put in their bad data. So,
Mm-hmm.
you know, we say in there the operative mortality is upwards of 25%. Well, that's a voluntary program. So I mean, at some
Mm-hmm.
programs it could be 90%, but they're
Mm-hmm.
not including it. The
Sure.
one thing that I'm not certain is being tracked is genetic results. Um,
Mm-hmm.
you know, and I'd have to look more into that, but I think that's something big that should be done.
Mm-hmm. I think we're still being told in the community that out of all AD patients, approximately 30% have a known syndrome or disorder, whereas the rest of us, I always tell everybody, the rest of us, we just don't know today. So I
Mm.
encourage people about every 6 or 7 years to go for genetic testing again. I think we're up to about a 38 aortopathy panel. I think 10 years ago it was like 32 or something like that when I first did it, and now there's more. And so
Yeah,
you're right. And the data that you get out is only as good as what's being put in. So at the end of the
right.
day, yeah.
Yeah.
And the last question I have here is, do you or your staff have a program in place for post-aortic dissection surgical patients to discuss things like post-perfusion syndrome, PTSD, depression? Is this part of like a cardiac rehab program? Do you have social workers who talk to patients in those first 2 months while they're healing as part of the home visit, just to get a sense of, because for a lot of us don't know that we have those, mental or emotional problems until it's been a year of sleeplessness, until it's been a year of, oh, so that's why I hear alarms and they're not really there. It takes a while
Mhm.
before you talk to people and you find out. So does your hospital do anything like that, or any thoughts about that?
That might be a better question for Selena if she's still on.
Okay.
To my knowledge, no. You know, and that is one of those tough things that you know, we see them like a month after surgery, and then usually 3 months, and then 6 months, and a year. And you're very right. That's oftentimes a lot of the discussion is like, hey, your scan looks good, and they're like, okay, well, see you in another couple months,
Right.
and it's like, you know, I kind of just tell them out of sight, out of mind until then.
Yeah.
But that's not true because it's not out of mind. You know, you have to go home and
Right.
live with that. But no, I do think that's a fantastic idea, and I think that everyone should have it.
Mm-hmm.
Quite literally, like by the time they go home from the hospital, they should have some survivors group just outreach. You know,
Mm-hmm.
it's a little bit like cancer, to be honest. It's, you know,
Yeah.
because it's a new thing that affects your entire body, and you don't know how to handle it, and I don't know how to handle it, you know, because
Right.
it hasn't happened to me. So all I can do is tell
Yeah.
them, you know, what to expect, but it's different for every person. You know, I
Well, and
do
I
think that
think
everyone should have it.
our dreams would be to see it become almost like a highly suggested, if not required thing, that if you're going to have to, when you're discharged, make an appointment with your cardiologist, right? You do that, pick up your medications, make an appointment with your primary care, all those things I was told to do. We're going to get you set up with cardiac rehab. And I think what should be added is a patient representative from a patient advocacy organization, so that you have all the tools So if you choose to want to reach out, there are people there. There's a whole community of people who've been in these steps before you that can validate everything you're feeling as being things that they felt. Because it's very scary navigating those first few weeks, months, hours. It could be hours once you've been released, and nothing happens when you're in the hospital. But when those first nights when your doctor's like, all right, I'll see you, go live your life, we leave and we're like, oh, what the hell does that mean? We don't know what it means. If I get a cold, am I going to implode if I sneeze? These are very valid questions that make me laugh now, but it's all true, and people need to be told this. And so unfortunately, like, we understand surgeons don't necessarily have the time. And I think it's being dissuaded more and more often. Just focus on the patients and the surgeries you've got to come versus holding the hand. So there needs to be a hand holder, and our patient support group meetings are led by patients. Who better to tell somebody what it's going to feel like when that chest tube comes out, when they tell you they're going to count to 3, but they pull it on 2. It's better for you, trust me, than waiting till 3. Who better to lead that group than someone who's already experienced it? So I think it would be nice to see, especially these larger centers, consider something like that with any organization. Yeah.
Yeah, I agree. Family as well. I mean, it's
Oh yeah.
Family members have to go home, and like I said, it's usually the wives or the husbands who are the ones who are saying, no, you're not lifting anything for
Yes.
the rest of your life, and
Right.
you're like, hey, can you tell them I can eat a cheeseburger?
Yeah,
but yeah,
exactly.
I think it's a whole family involvement, unfortunately.
Right. Answer the call. I'm going to track you now. I know I'm on Apple and you're on Android, but we got to figure this out. I want to, because if you don't answer when I call, you're probably actually dead in a ditch. Like and that's a whole other thing, the caregiver mindset, what they go through, and how do they know when it's okay to give a little bit more and to let the leash go? And then the patient doesn't understand why they're that way because we're so consumed with our own thoughts. So it's a whole other dynamic that I've watched and I've learned about, over the last 10 years with this community, and it's fascinating. But what we've been able to do is have guests like you on to really give this community a chance to ask the questions, to get some of these things answered, to learn. And that was a very easy way to understand. This was a great presentation on dissections. So thank you again. I want to check with Josh and just see if we have any other questions, because then I have like 3 myself before I let you go for dinner. Real quick. Josh,
right,
anything else? Good.
So we have a thing here. This I was unaware of annual CT scans. And so Dan here says, I understand now. My aneurysm was repaired, so no annual CT scans. And I said, clarify repair. No not dissected. And he goes, glowing is the fun part, because that's where we were in the conversation when you were talking about the overexposure to CT scans. And he says, yes, repair, no dissection. Now, does that get him off of a CT annual visit?
Yeah. I think the guidelines are still 5 years. Some will do 2 or 3, or you can spread out a little bit earlier. But you do have an aneurysm, so you're genetically, or in some way, you have some aortic disease. But I would say for at least the 5 years, and then after that, just space it out. Again, maybe not annual, but every 2 to 5 years. And again, at that point, an MRI might be good. But yeah, the aneurysm and not a dissection definitely changes it from, for sure, annual to every other year, every 3rd year, something like that.
Mm-hmm.
Fair enough, Dan. You heard it here, brother.
All right. Pseudoaneurysm. We didn't get to that, but that's a term that people talk about a lot, and it sounds super scary because it probably is kind of scary. But what exactly is it?
Yeah, so it is super scary for the most part. I mean, it's very rare to see them in somebody who has not had a repaired aorta in some fashion. Usually when we see them, it is, so a real aneurysm is a dilation of all 3 layers, the intima, the media, and the adventitia. A pseudoaneurysm is a dilation or a containment, usually just by the adventitia itself. So you have this tiny layer of either adventitia or scar tissue, which is usually what we see, holding everything together. So you can almost think of it as a contained rupture. So a rupture, but hasn't, there's scar tissue from your previous heart surgery or whatever is going on that's containing it. yeah, pseudoaneurysms can be very dangerous. Usually you can wait on them a little bit, like if somebody comes in and you see it on the CT scan, it's not like, oh, we have to rush you to the OR today, but probably in the next day or two.
So if that bursts, is that like a rupture, or are you still have a layer? Oh, so you don't even protected by the other two layers.
Right. Yeah.
Okay,
Yeah.
so that's really not very good. All right.
Yeah.
So those of you that have pseudoaneurysms, I'm so sorry, but you need to definitely stay on top of that if anybody said anything to you about that. Okay. Well, thank you for explaining so much to me, especially about the percentage and risks of death, imminent death, and stuff of that nature when having a dissection. And I think there's also the individuals that just think they have reflux or they pulled a muscle, and it's so the pain or discomfort so mild that they're unsure. And that's the unfortunate thing. If you're not, that's why we try to at least press upon people to know your family medical history, right? Because if you know that you have a history of aneurysms, it could be high blood pressure, stroke, diabetes, cancer, all of that, then you should have yourself receive some kind of baseline monitoring just to know this is where you're at. Are you at risk? So that if you do feel something that's off, you don't dismiss it as it's just off, because it could be something that you just didn't know was going on inside of you.
Right.
So, yeah. Do we have any other things, Josh, before I let the doctor go for his din time?
That is all I have for
Wonderful.
you. Thank you very much,
Well,
Doctor.
Yeah, Dr.
Thank you.
Sbrocchi, thank you. It was so great to have you here. I love having first-time physicians with us online. I hope you consider doing this with us again.
Yeah, absolutely. Yeah,
I mean, we
had a
do
great
have
time.
Aortic Disease Awareness Month coming very, very soon in September. So I'll definitely reach out and see if we can get you as a guest again. I'll let you pick the topic this time, something that really excites you. I mean, we know that you're really excited by heart surgery and thoracic surgery. So anything you want to talk about would be great. We'll go into the aortic valve this time and we'll talk about all of that fun stuff. Maybe have some
that'd be
show
great.
and tells for us.
Yeah,
All right.
yeah, that'd be great.
Thank you again. Everybody, do me a favor. Don't forget, click like, click subscribe, click the bell so you're notified every time we go live, and share this, because I guarantee you there's somebody in your life that's probably not in this community right now that would benefit from the information that was shared tonight. So thank you again so much, and have a great rest of your week. Take care.